Hello, I am Gary Mintz from the Cardiovascular Research Foundation, and I would like to introduce the overall concept of TCT2021 at TCTAP. This 2-hour session is based upon presentations at last fall's in-person TCT meeting. There are 3 parts to the session. The first one having to do with coronary physiology, the second one with structural heart disease, and the third one is a live case from Emory. So without further ado, I'd like to turn this over to Greg Stone, who will introduce our 3 talks. Greg?
Well, thanks, Gary. So we're really excited about these 3 talks, and the first one will be presented by Matthias Gottberg from the Skane University Hospital in Sweden, and this is from the fantastic IFR Sweetheart study, the 5-year outcomes of a randomized trial of IFR-guided versus FFR-guided PCI. Matthias?
Thank you very much. It's a pleasure to be here and present the data on behalf of the investigators. Today I'm going to talk about IFR Sweetheart trial and the 5-year final outcome. Here are my disclosures. So, instantaneous wave field ratio, or IFR, is a non-hyperemic or resting index used for assessment of coronary lesion severity. Numerous previous validation studies have demonstrated a similar or even improved ability to accurately detect ischemia compared with the fractional flow reserve, or FFR. The study design of IFR Sweetheart demonstrated that IFR was non-inferior to FFR at 1 year regarding a composite of all-cause death, MI, and unplanned revascularization. The study design had a non-inferiority margin of 1.4 and required 2,000 patients with 85% power to test the hypothesis of non-inferiority. The primary endpoint was presented at ACC 2017 and subsequently published in New England Journal of Medicine. And today we're discussing the final follow-up at 5 years. So a bit of the study design in itself. IFR Sweetheart is a randomized clinical trial. It's in fact a register-based randomized clinical trial. In other words, we're using national web-based quality registers as an electronic case report form, or CRF, to input baseline characteristics, procedural data, but also do online randomization and clinical follow-up. This is a proven, pragmatic, and very cost-effective trial design facilitated by the use of unique personal identifiers in Scandinavia, which allows us actually to track 100% of our patients. Here are the major inclusion-exclusion criteria. Is mainly patients with suspected stable angina or unstable angina or non-STEMI. We also needed to have a clinical indication for physiology-guided assessment correlations with a recommendation of 30 to 80% stenosis grade. Exclusion criteria were few: known terminal disease with low life expectancy, unstable hemodynamics, previous CABG, or heavily tortuously calcified vessels where we didn't think we could cross with the pressure wire. 2,037 patients were enrolled at 15 Scandinavian sites between May 2014 and October 2015, and no patients were lost to follow-up, neither 1 year nor 5 years. In terms of baseline clinical characteristics, there were no differences between the patients. You can see a little less than 2/3 of patients have stable angina as an indication for angiography. We also noticed that more lesions were evaluated in the IFR group, but fewer lesions were significant. This is partially due to a lower threshold to perform IFR compared with FFR, but also could be some classification differences between the 2 indices. In terms of the primary composite endpoint at 12 months, we found a 6.7% event rate in the IFR group, a 6.1% in the FFR group with a hazard ratio of 1.12. Fulfilling the pre-specified non-inferiority margin criteria and demonstrating that IFR was in fact non-inferior to FFR regarding the primary composite endpoint at 12 months. We also assessed chest discomfort during the procedure, and we saw only 3% of patients in the IFR group experienced mild discomfort during the procedure, whereas 2/3 of patients in the FFR group experienced discomfort ranging from mild to severe due to the adenosine administration. And now at the 5-year final outcome, we saw the composite endpoint, an IFR event rate of 21.5%, an FFR event rate of 19.9%, with a hazard ratio of 1.09, demonstrating no difference in the composite outcome compared with the FFR at 5 years. In terms of the constituents of the primary outcome, all-cause mortality with an IFR event rate of 9.4%, with an FFR event rate of 7.9%, with a hazard ratio of 1.20, but no statistical differences between the two groups. In terms of myocardial infarction, an IFR event rate of 5.8%, FFR event rate 5.7%, with a hazard ratio of 1.0, and the curves virtually overlapping. Yet again, no difference between the two groups. In terms of unplanned revascularization, IFR group, we had 11.6% event rate, and in the FFR group, 11.3%, with a hazard ratio of 1.02, and yet again, no statistical difference between the two groups, virtually overlapping curves. We also looked at the composite endpoint at 5 years in terms of subgroups: age, gender, hypertension, hyperlipidemia, diabetes, smoking status, and also angina status or indication of angiography. And we couldn't see any difference in outcome in any of the pre-specified subgroups. We did a further analysis of the cause of death because we saw this numerical increase with a hazard ratio of 1.20. And we divided the groups between cardiovascular death and non-cardiovascular death. And we noticed that 2/3 of deaths in the group were of non-cardiovascular origin. And this is likely due to this is a very unselected all-comers population in the SWEDART trial. We could also see that there were borderline significantly more non-CV events in the IFR group, and this was mainly attributed to cancer or septicemia. However, when looking at the CV death rates, they were very similar between the two groups with a hazard ratio of 0.85 and no statistical difference, but numerically fewer deaths in the IFR group. So if I may summarize, among patients who present with stable angina or acute coronary syndrome, when performing invasive physiology with IFR, we provide similar long-term outcome compared with FFR. And this is true both for the composite endpoint for all-cause death, MI, and unplanned revascularization, as well as the constituents of the primary composite endpoint, as well as the composite endpoint in pre-specified subgroups. And this paper is currently in press with Jack and will hopefully be published in the coming week or so. So on behalf of the IFR SWEDART investigators, I'd like to thank everyone.
Fantastic, Matthias, and thank you for staying on time. It seems like a very, very clear message, but there's certainly some interesting points that I'd like to discuss. But let's go on and complete our next 2 lectures, and then we'll have time for discussion. Continuing the physiology theme, the next study is very exciting and important, perhaps the future of physiology. And this is the FAVOR-3 China trial, a sham-controlled randomized trial comparing QFR-guided and angiography-guided PCI. And this will be presented by Zhu Bo from the Fuwai Hospital in Beijing, China.
Also, thanks to the organizers for inviting me to participate in this important joint session. Here's my disclosure. Actually, the FAVOR-3 China trial was supported by 3 institution grants. As we know, compared with visually angiography assessment, pressure wire-based physiological measurement more accurate identify flow limiting lesions. However, the method is largely underused in practice due to multiple reasons. The quantitative flow ratio, QFR, derived from 3D coronary artery reconstruction and flow dynamics computations from the angiogram, enable online estimation of FFR without the use of a pressure wire or pharmacological agent to induce hyperemia. Prior studies have demonstrated the feasibility and accuracy of online QFR compared with FFR measurement. With the lesion selection for PCI, using a QFR-guided strategy might improve clinical outcome compared with a standard angiography guidance strategy is now known. This slide illustrates the QFR calculation by using angioplast system in the trial. However, today in our practice, we are using the new version, which needs only 1 frame and enable faster calculation within 1 minute. The study was an investigator-initiated multi-center sham-controlled blinded randomized trial. Patients meet all general angiography inclusion criteria. Before the randomization, one important and unique step is the operator must declare the target vessel intended to be treated with a standard angiography guidance. And then 3,830 patients will be randomized in 1-to-1 ratio to either QFR guided strategy or angiography guided strategy. QFR was measured in all coronary arteries containing any lesion with visually assessed diameter stenosis between 50% and 90% and RVD greater than or equal to 2.5 millimeter. Then the treatment will follow by a cutoff of QFR value 0.80. In angio group, PCI was performed based on visual angiography assessment per local standard for practice. In the clinical follow-up was scheduled at 1 month, 6 months, and 1 year, annually up to 5 years. The primary endpoint was 1 year MACE, accompanied of all-cause death, MI, or ischemia-driven revascularization. We also had a powered major secondary endpoint is 1 year rate of MACE excluding periprocedural MI. And you can see we have a lot of other secondary endpoint, including the cost effectiveness and the quality of life outcome until 1 year, which will be announced later this year. For patient flow, you can see between December 2018 and January 2020, among 390 days, we randomized 3,847 patients at 26 centers. After further excluding 22 patients who withdrawn consent, and finally 1,913 were included in the QFR group in ITT population and 1,912 in angiography guided group. The 1 year clinical follow-up complete in 99.4%. If you look at the baseline characteristic, very well matched between groups, mean age 62.7 years old, male more than 70%, 34% diabetes. The clinical presentation, majority of our population are unstable angina, 58% and 25.8% are stable angina. Anatomic syntax score, functional syntax score, EGFR, LVEF are well matched between groups. Multivessel disease more than 50%, and any lesion with severe stenosis or subtotal stenosis around 9% in each group. The online QFR was calculated in QFR group almost 100%, and the mean calculation time 3.9 minutes. The online QFR value 0.70. The vessels with online QFR value less than equal to 0.80, 75.2%. Among them, only 1.9% were actually not treated. To me, this is the second most important slide, how QFR guidance changed the strategy. At baseline, before the randomization, vessels intended to be treated well balanced between groups. But after randomization, vessels actually treated of those originally intended was dramatically changed. You can see more LAD, less circumflex in QFR group was treated compared with the angio group. In the vessel level analysis, vessels actually treated of those originally intended were 84.4% in QFR group versus 95.7% in angio group. In patient level analysis, patients with any intended vessel deferral or unintended vessel treatment were 23.3% in QFR group versus 6.2% in angio group, including deferral 19.6% and unintended vessel treatment 4.4% in QFR group. So we can understand this strategy change significantly impacted on the key procedural result. You can see less PCI performed 90.5% in QFR group versus 99.1% in angio group. Also, we can see the number of stent, contrast media used, X-ray time, procedure time, or all less in QFR group as compared with the angio group. However, the PCI lesion success was similar, and the residual functional syntax score indicating functionally complete revascularization rate was much higher in QFR group as compared with the angio group. So for the primary endpoint, 1 year MACE, you can see these two curves separate in the first 48 hours, indicating a between group difference of periprocedural MI. And the two curves continued to be more diverged. The 1 year Kaplan-Meier estimates 8.8% in angio group and 5.8% in QFR group, resulting in a 3% absolute risk reduction and 35% relative risk reduction. When we further excluding the periprocedural MI, you can see this major secondary endpoint. These two curves were gradually and beautifully separate from the beginning to 1 year, 4.8% reduced to 3.1%, resulting 36% relative risk reduction. This slide summarizes the 1 year clinical outcome. Again, the primary endpoint 5.8% in QFR group versus 8.8% in the angio group, mainly driven by fewer myocardial infarctions, 3.4% in QFR group versus 5.7% in angio group, and fewer ischemia-driven revascularization procedure, 2% in QFR group and 3.1% in angio group. Interestingly, both periprocedural MI and the non-procedural spontaneous MI was reduced by QFR guidance. So in conclusion, in the multi-center randomized sham control trial, a QFR guided vessel lesion selection strategy improved 1 year clinical outcome compared with the standard angiography guidance in patient undergoing PCI. The benefit are due both to fewer procedural complications and superior long-term results with less MI and repeat revascularization procedures. The simplicity and safety of QFR compared with wire-based physiological measurement should facilitate the adoption of physiological lesion assessment into our routine clinical practice. Last but not least, I want to thank all the 479 investigators, particularly our great international advisory board. Thank you very much for your attention.
Thank you, Bo. Because I want to save some time for discussion, we're going to go right to the third presentation, and that is the FAME-3 trial, a randomized trial of FFR-guided stenting compared with bypass surgery. And this will be presented by Bill Fearon from Stanford University Medical Center in California.
Okay, thank you for the invitation to speak about fractional flow reserve guided PCI compared with coronary artery bypass surgery, the FAME-3 trial, on behalf of the FAME-3 investigators. These are my disclosures. Previous studies have demonstrated improved outcomes with coronary artery bypass graft surgery compared with PCI in patients with 3-vessel coronary disease. However, most trials used bare metal stents or first-generation drug-eluting stents. In addition, none of these studies measured fractional flow reserve to guide PCI. The hypothesis of the FAME-3 trial was that in patients with 3-vessel coronary disease, FFR-guided PCI with a current-generation drug-eluting stent would be non-inferior to CABG with respect to 1 year major adverse cardiac and cerebrovascular events. This study was sponsored by Stanford University. Funding came from research grants from Medtronic and Abbott Vascular. There was an independent clinical events committee and data safety monitoring board, and the study was coordinated and data analyzed by those listed on this slide. This was an investigator-initiated, multi-center, randomized controlled study, including all comers with 3-vessel coronary disease not involving the left main, that were felt to be amenable to PCI and CABG by each site's heart team. 48 sites participated in Europe, North America, Australia, and Asia, and patients were randomized in a 1-to-1 fashion to either FFR-guided PCI, where all lesions with an FFR less than or equal to 0.80 underwent stenting, or to coronary artery bypass graft surgery. The primary endpoint was the 1-year rate of major adverse cardiac and cerebrovascular events, including all-cause death, myocardial infarction, stroke, or repeat revascularization. The non-inferiority margin was set at a hazard ratio of 1.65. In order to be included in the study, you had to have at least 50% diameter stenosis in all 3 major epicardial vessels without left main involvement. Key exclusion criteria included cardiogenic shock, a recent STEMI within 5 days, or a low left ventricular ejection fraction. Patients randomized to FFR-guided PCI were preloaded with a P2Y12 inhibitor and high-dose statin. FFR was measured with intracoronary or intravenous adenosine. PCI was performed with the Medtronic Resolute stent only if the FFR was less than or equal to 0.80 as measured with the Abbott pressure wire. Post-PCI FFR measurement was recommended, and dual antiplatelet therapy was continued for at least 6 months. In the CABG patients, FFR-guided CABG was not mandated, but FFR information from the diagnostic angiogram could be used if available. Patients were pretreated with aspirin and high-dose statin. On or off pump bypass was acceptable. A lima was to be used in all cases. Complete arterial revascularization was recommended. 1,500 patients were included in FAME3, with 757 randomized to PCI and 743 randomized to CABG. Very few patients crossed over, withdrew, or were lost to follow-up. The baseline characteristics are shown on this slide. The average age was 65, with the majority of patients being white men. Typical risk factors were present, including about 30% of patients having diabetes, 40% presenting with an acute coronary syndrome, and almost 15% having had a prior PCI. The time to procedure, the procedure duration, and the length of hospital stay were all significantly shorter in the patients undergoing PCI compared with CABG. The number of lesions identified were similar at just over 4 lesions per patient. About 20% of patients had a chronic total occlusion, and 2/3 had a bifurcation lesion. The mean syntax score was 26. In the PCI patients, FFR was able to be measured in 82%, and 24% of these had an FFR above 0.80. 3.7 stents were placed on average with a total stent length of 80 millimeters. Intravascular imaging was used in 12%, and FFR was measured after PCI in 60%. FFR was measured prior to bypass surgery in 10%. 3.4 distal anastomoses were placed. 25% of patients had multiple arterial grafts. A lima was used in the vast majority, and about 25% had off-pump surgery. The primary endpoint was the composite of death, myocardial infarction, stroke, or repeat revascularization at 1 year. And you see that this occurred in 10.6% of the patients randomized to PCI and 6.9% of the patients randomized to bypass surgery. The hazard ratio was 1.5, with the upper bound of the 95% confidence interval at 2.2, which was greater than the non-inferiority margin, which was set at 1.65. So the study did not meet the preset criterion for non-inferiority. The p-value was 0.35. When looking at the components of the primary endpoint, there were no significant differences between each component, and the composite of death, MI, or stroke was also not significantly different, although numerically lower in patients randomized to bypass. Safety endpoints showed significantly lower rates of severe bleeding, acute kidney injury, and significant arrhythmia in patients randomized to PCI. Definite stent thrombosis and symptomatic graft occlusion were rare occurrences, and rehospitalization within 30 days occurred in significantly fewer patients randomized to PCI. On subgroup analysis, we see some trends based on patient age and sex, but the most remarkable finding was the interaction based on syntax score. Patients who had a low syntax score, less than 23, who were randomized to FFR-guided PCI actually had lower MACE rates compared to those randomized to CABG. Whereas in the intermediate and high syntax score groups, the reverse was seen with lower rates with bypass. It's important to compare FAME3 to the historical control, the syntax trial. You see here the baseline characteristics in both studies, and you see that the patients included in FAME3 were very similar to syntax based on age, sex, risk factors, and syntax score. But interestingly, in FAME3, the rates of MACE were lower in both the PCI and the CABG patients when compared to the CABG patients in the syntax score. It's also important to understand how procedural myocardial infarction was defined in FAME3. It was defined in the same manner for patients undergoing bypass and PCI. That way, the clinical events committee could adjudicate the events in a blinded fashion. It required a troponin elevation, as well as at least one of the following: new pathologic Q waves, new graft or native artery occlusion, or new loss of viable myocardium on imaging. So this was a fairly strict definition, and for that reason, the rates of procedural MI were low, both in the PCI and the CABG patients in FAME3. There is another definition of procedural MI that was put forth by the Society of Cardiac Angiography and Interventions. This definition includes two criteria. One is just a biomarker elevation of CKMB 10-fold above the upper reference limit, or troponin 70-fold, or a biomarker and new Q waves on the EKG. This definition has been shown to be prognostically important after revascularization. And when you apply this SKY definition, you see that, first of all, the rates of procedural MI were significantly higher in both groups of patients. But you also see that there was about a 4% difference favoring PCI using the SKY definition. So this would have altered the interpretation of the trial if this definition had been used. There are some limitations, of course, to FAME3. 1-year follow-up is relatively short term. Patients will be followed out to 3 and 5 years. FFR measurement was not mandated in patients undergoing bypass, although studies have never shown that FFR-guided CABG really outperforms angio-guided CABG. Intravascular imaging was utilized in only 12% in the patients randomized to PCI. But in the SYNTAX-2 trial, which had similar patients and which used intravascular ultrasound in 85%, the MACE rates were actually identical in both PCI groups. Completeness of revascularization data are also not yet available, and we hope to have those data soon. In conclusion, in patients with 3-vessel coronary disease, FFR-guided PCI with a current generation drug-eluting stent did not meet the criterion set for non-inferiority in comparison with CABG in terms of death, MI, stroke, or repeat revascularization at 1 year. The 1-year rate of death, MI, or stroke was not significantly different between the two groups. In FAME3, MACE rates for both FFR-guided PCI and CABG were lower than with CABG in the SYNTAX trial. FFR-guided PCI with a current generation DES performed favorably in comparison with CABG in 3-vessel coronary disease patients with less complex disease, according to the SYNTAX score. However, in patients with more complex 3-vessel disease, CABG remains the treatment of choice. For more information on the FAME3 trial, please refer to the paper published in the New England Journal of Medicine. Thank you for your attention.
All right. Well, unfortunately, we only have 6 minutes for discussion, so let's try to get at least 1 point from each study. I'll open this up to the panel. Let's go in order. FFR versus IFR. For our clinicians, is this a settled issue? When would you use IFR? When would you use FFR? When might you use both during a case?
Well, that's a $1 million question, isn't it? I think it comes down to saying that we know that outcome is similar. We haven't really found any differences in any subgroups between the two indices. So I think it's safe to say you can use either. Then I personally have a preference with IFR because it's actually easier to do a full lesion mapping, especially in more complex disease, especially in the LAD, to know where you want to send if you have a positive physiology. So I'm of course leaning towards IFR, but I think the overall message is what you should do is you should perform coronary physiology, because with multiple trials have shown that it's beneficial to the patient.
So Ajay or Roxana or Kiko, Gary, what do you do if you get an IFR of 0.92 or an FFR of 0.81 or 0.84? Do you pull out the other one, and then do you believe it if one is low and the other one is not?
I think for me, at least, the good news for the patient is that irrespective of what it is, there's no third arm of the trial of medical therapy alone. And so the reality is that patient is generally going to do pretty well from a prognostic standpoint. And then in terms of the treatment decision, it depends on what the patient's symptoms were. And so those are cases where I might use adenosine to kind of arbitrate in somebody with very typical symptoms to be sure. But I should also think about microvascular disease in that case as well.
Absolutely. And we've got to remember, this is just a test. It's one piece of information that needs to get incorporated in the decision-making for the patient. All right, let's go on to QFR because of time. Have you seen, the panel, have you seen enough data that that a QFR guided strategy, at least with the Pulse Medical System, is now been sufficiently validated that you don't need invasive pressure wire physiology anymore, and that you can use this for 3-vessel assessment and decision making?
Greg, I'm Greg, it's Roxana. Yeah, thank you for having me. I'm fascinated by the QFR study. I think it really is a very well conducted, incredible study that shows amazing outcomes. So you might imagine, why would we need invasive physiology? But I think, with all due respect, whenever you see one study, you always want to have that. And it would have been nice to actually have seen an arm with the invasive measurement. And I mean, I think it would be difficult to do with all of the randomizations, but certainly it's an incredible way forward. I'd like to learn more about what it takes to do QFR. And do you have to have specialized people? And, we discussed a lot of that, but certainly it's a fascinating study and you all should be congratulated.
Yeah, and there is go ahead, Akiko.
Yeah, also please elaborate a little bit more why the QFR is better than angio, especially sometimes the angio showing the non-significant, but the QFR show the significant. And did those lesions make the difference of the outcome?
Yeah, for long-term superiority benefit, it was actually mainly driven by the unplanned treatment for those lesions.
But there were also angio. There was also angio deferment, right, Shubo? There was also angio deferment. About 100 lesions were deferred by angio.
Yeah,
I think it's a really good question Akiko asks.
Yeah, agree.
So, and there is a outcomes trial that's ongoing, the Favor 3 Europe trial, which is comparing the same QFR system against an FFR guided strategy. Yeah. All right, quickly to FAME 3. In many ways, the most controversial study. Basically, it showed very similar to what we've seen in other studies in triple vessel disease, although the rates continue to get better and better. But these outcomes are very sensitive to the primary endpoint definition. The outcomes would have been totally different with the SKY definition of peri-procedural MI versus the protocol definition. And also, when you look at the safety outcomes, I don't know if the patients would have agreed, especially with a 5% rehospitalization rate for complications. That's much worse than the hospitalizations. So how do we start thinking about the overall outcomes of two totally different procedures, like bypass surgery versus PCI, where patients really want to live longer and feel better? Are we too simplistic in our thinking of the way we're measuring these endpoints? Whoever wants to take that.
So, I mean, I'll take it, Greg. Obviously, having repeat revascularization in that endpoint, it was, I'm not surprised by the findings. There's no question. We've already known this. There's no real unknown about the fact that when you have repeat revascularization, it's very hard to win, even if you're doing FFR guided PCI, because of the nature of the procedures. And I think that, yes, you know, you can come back and say that, well, quality of life is incredibly important, and absolutely it is. But all of those measures are difficult to accomplish. So if you do a quality of life assessment, you know, 6 months after a CABG versus a PCI, I can promise you that the PCI arm will win. And if you go and down the line for a longer term follow-up, which we do not have, it's very hard to get quality of life measures depending on, you know, what the patient's understanding is and their memory of their procedure versus PCI. Obviously, CABG is a much more invasive, and it is well established that you're going to have early complications. You showed that in Excel. And I think that, you know, this is a difficult question and a new one. And I think in our institution, what we do is we bring in the patient, and it's a shared decision-making within the heart team. And I think it comes back to that heart team of taking pluses and the minuses. And I think PCI is a choice for a really a good number of patients, depending on what it is they're looking for the outcome.
And Greg, if I could just make one quick, and
I was going to ask you a specific question for the last.
Yep.
Let me just respond to Rox real quick, and then I want to give you the last word.
No, I was going to, yeah, go ahead, Greg. No, go, Greg.
So I was just going to say that there's no doubt how important quality of life is, because that's really why all patients want to choose PCI over CABG, because of that early major difference in quality of life. And we do have tools that can measure this, and it has been measured out to 3 years in Excel and 5 years in Syntax. But Gary, I wanted to give you the last word. You may say whatever you want, but only 10% intravascular imaging in FAME3, that's been criticized. My point is that's what people are doing, at least, you know, approximately in the United States and Europe. So what say you? Would that have made the entire difference if people use imaging as much as some of us believe that they should?
If they had used imaging and had used it properly to optimize the stent, I believe the study would have been totally different. I accept the fact that's not what people are doing, but you're also trying to compare the best of one strategy versus the best of the other. And it's not as if everybody going to the cath lab gets FFR guided PCI anyway. That's not what people are doing. So, I mean, I would have tried to have the best PCI against the best CABG, and then the winner takes all.
Well, thank you, Gary. And I thank all the moderators. This has been an amazing session. We could go on for an hour, but we have to go on to the next TCTAP session. So I'll close this session. Thank you all.
Thank you.
Hello, welcome to the TCT Asia Pacific session. This is the second part of the TCT contributions to the annual course in 2022, which is a virtual online course. The first session dealt with ischemic heart disease, and we're thrilled to present a series of presentations which come under the category of structural heart disease. I'm delighted to introduce my co-moderators, the Venerable Eberhard Grube from Germany, my colleague and friend Juan Granada, the CEO of the Cardiovascular Research Foundation. We'll have 3 speakers that will present 3 important clinical trials that were presented at TCT 2022. The first will be Nicholas van Meegen, then will be David Cohn, then Sushil Kodali. This will be followed by a discussion. Then we'll have a Shark Tank session to discuss new technologies in structural heart disease. And we'll finish this 1-hour presentation with a fabulous edited case of a new technique to treat obstructive hypertrophic cardiomyopathy. And it's the team from Emory University, and Adam Greenbaum will help to moderate and answer questions on this case. So let's begin with the first session, which are 3 brief clinical trial presentations. The first will be done by Nicholas von Meegen, and he will be talking about the 5-year outcomes of the SURTAVI trial, which is a self-expanding TAVI in patients at intermediate risk.
Dear colleagues, in the next 10 minutes, I will discuss the 5-year clinical and echocardiographic outcome from the randomized SURTAVI trial, and I'll do this on behalf of the SURTAVI trial investigators. These are my disclosures. And as a background, we know from early randomized trials that were performed in patients at high operative risk with reserved long-term prognosis that TAVI equals or at least is as good as surgical aortic valve replacement. But these patients were elderly patients with a lot of comorbidities, so their long-term life expectancy was short. At the same time, there is an intermediate risk trial, partner 2, with 5-year follow-up that has been presented and published and showed that there was no difference between TAVR with a 2nd-generation balloon expandable valve and surgery at 5 years in terms of mortality and disabling stroke. However, between 2 and 5 years, there was an incremental risk for mortality, but also more re-interventions and re-hospitalizations with TAVR versus surgery. And there is limited long-term data for the self-expanding valve TAVI versus surgery. And this is where the randomized SURTAVI trial comes in. As a design, patients at intermediate operative risk were randomized to either surgery with a bioprosthesis or TAVI with a self-expanding supraannular transcatheter heart valve. In the majority of cases, this was a 1st-generation core valve. Only in a minority, only in 16% of the patients, the Evolut R valve was being used. At this point in time, in the Western world, we use the Evolut Pro Plus, which is a device iteration that allows for repositioning and retrievability, but also has a sealing skirt to mitigate paravalvular leaks. In the majority of cases, the transfemoral approach was used for the patients in this trial. So the study methods is according to the standards of contemporary randomized controlled trials. There is a clinical event committee to adjudicate independently clinical events, and there's also a core lab to address independently echocardiograms at pre-discharge, 30 days, 1 year, 5 years, and 10 years. For the statistical methods, suffice to say that the primary analysis is on a modified intention to treat that is defined as those patients undergoing an attempt of the assigned treatment. Overall, 864 patients were enrolled in a modified intention to treat versus 796 patients in the surgical cohort, and follow-up was complete in way over 90% for both treatment arms. So that is quite good. The key clinical outcomes are a composite of all-cause mortality and disabling stroke. Also, indices of valve durability as addressed by the core lab. Also, we looked at endocarditis and thrombosis, and further on indices for health status of the patient. These are the baseline characteristics. We're not talking about young patients. We are still talking about patients who are more or less octogenarians. So the mean age was 79.9 years old, 40% or so were female, and the STS predicted risk of mortality was below 5%. So I think clearly an intermediate risk population, but at the same time, 50% of the patients had at least an index of frailty on board. So we're not talking about low-risk patients. First, the primary composite endpoint of mortality and disabling stroke. Out to 5 years, no difference in outcome between the two treatment strategies. Furthermore, if you do a landmark analysis, and that is interesting because basically you start to count again at 2 years and see what happens afterwards, then again, you see that the two curves are superimposed. Also, for mortality, no difference. For disabling stroke, no difference, although there was a trend in favor of TAVI over surgery. This slide summarizes the key clinical outcomes, and let us focus on reintervention rates. On the left-hand side, you see the event rate out to 2 years, in the middle to 5 years, and on the right-hand side between 2 and 5 years. Now, what is noticeable is that there are more reinterventions at 5 years in the TAVR arm, but all these reinterventions, or the difference in reintervention rate between TAVI and surgery, specifically occurred early after the procedure. As a matter of fact, between 2 and 5 years, only 6 patients in the TAVI arm and 7 patients in the surgery arm required a reintervention. So basically, there is no signal of late structural valve degeneration with TAVI versus surgery. In terms of valve endocarditis and valve thrombosis, it's fair to say that the numbers were very low. Only 1% of valve endocarditis with TAVI at 5 years versus less than 2% with surgery. Valve thrombosis below the 1% rate. In terms of aortic valve or heart failure related hospitalizations, the event rates were also no different between the two treatment arms out to 5 years. This is interesting, again, this landmark analysis, because it shows you what happened with the reintervention. So at 5 years, there's a difference in the reintervention rate between the two treatment arms. But if you look at what's happening after 2 years, no difference whatsoever between the two treatment strategies. And the same thing is clear for rehospitalizations. There was a clear trend in favor of surgery out to 2 years, but between 2 and 5 years, no more difference between the two treatment strategies. In terms of valve hemodynamics, as expected with a supraannular self-expanding transcatheter heart valve, the valve area is larger as compared to surgery and the residual gradients are lower. But that comes at the price of more paravalvular leaks. So there were more paravalvular leaks with TAVR versus surgery out to 5 years. Interestingly, the presence of paravalvular leak did not predict or was not associated with 5-year mortality. In terms of health status, we know that patients after TAVI will respond sooner, will improve sooner, but at 1 year, there is no longer a difference in quality of life between the two treatment strategies, and basically this remains stable out to 5 years. Same for New York heart status, no difference between the two treatment strategies. So in summary, at 5 years following TAVI with a self-expanding supraannular functioning valve, and in patients at intermediate risk, there is no difference with surgery in terms of the primary composite endpoint of mortality and disabling stroke. We did see more reinterventions after TAVI, but that was predominantly because of more early reinterventions, and you can imagine the situation, especially with this early generation core valve, that there were patients leaving the cath lab with some residual paravalvular leak that was underestimated during the index procedure, and then the patient was brought back within the first following months after the procedure. Between 2 and 5 years, no difference in reinterventions. As a matter of fact, all the major clinical endpoints were similar between the two treatment strategies. Forward flow hemodynamics were superior for TAVI over surgery, but then again, surgery was associated with less paravalvular leak. And for both treatment strategies, there were low rates of thrombosis and valve endocarditis. Thank you for your attention.
I'm thrilled to introduce my colleague from the Cardiovascular Research Foundation, David Cohn. He'll be presenting the long-awaited Partner 3 2-year economic outcomes data, which is a randomized trial of TAVR versus surgery in patients at low surgical risk. David?
Thank you very much, Marty, and thanks to the organizers for inviting me to share these results, which were first presented at the TCT meeting back in the fall. The Partner 3 trial and the data I'm going to be present were funded by research grants from Edwards Life Sciences. By way of background, we know that previous studies have demonstrated that TAVR is a cost-effective therapy compared with medications for patients with severe aortic stenosis and extreme surgical risk, and also compared with surgical AVR for patients at both intermediate and high risk. Recently, based on the results of both Partner 3 and the Evolute low risk trials, TAVR has been approved in the United States for low risk patients as well. However, at the present time, there is little evidence as to whether TAVR is cost effective compared with surgical AVR for low risk patients. And so we performed, to understand this, we performed an economic study alongside the Partner 3 trial. To refresh your memory, the Partner 3 trial enrolled 1,000 patients with symptomatic severe aortic stenosis who were at low surgical risk, and STS predicted mortality risk by the heart team of less than 4%. They were randomized in a 1-to-1 fashion to either transfemoral TAVR using the SAPIEN 3 valve or surgical aortic valve replacement using any surgical bioprosthesis. The economic analysis that I'm going to present was pre-specified. It was performed from the perspective of the United States healthcare system. The population consisted of all the United States patients who underwent TAVR or SAVR, a total of 929 out of the 1,000. And the outcomes that we collected in the trial were costs which were based on linkage of the patient data to Medicare data in the United States, life years and quality adjusted life years through 2 years. And I'll talk more about those as I show those data. The primary cost effectiveness analysis was based on the in-trial period. So based on the observed costs and quality adjusted life years from the 2-year in-trial analysis, which is functionally equivalent to assuming no further differences in cost or survival beyond 2 years. And we use bootstrap resampling to assess the joint uncertainty in those parameters. Then we did a number of important sensitivity analyses, one set looking at minimalist TAVR by reducing ICU and length of stay for patients without complications. And then finally, very importantly, some alternative assumptions regarding the outcomes beyond 2 years. In terms of the data from the trial, this slide summarizes the index hospitalization resource utilization. Not surprisingly, TAVR led to marked reductions in all measures of resource utilization. Procedure duration was more than 2 hours shorter with TAVR than surgical AVR, and the length of stay was about 4.5 days shorter over the entire hospitalization. You can see there were marked differences both in ICU as well as in non-ICU length of stay. And finally, there were important differences in discharge disposition for the patients. About 96% of the TAVR patients were discharged directly to home under self-care, whereas this was only done in about 73% of the surgical AVR patients, and about 15% of those surgical AVR patients actually went to a rehab or skilled nursing facility, which is fairly expensive in the United States. This graph will summarize the index hospitalization costs. Shown here in red are the procedural costs, which were substantially higher for TAVR than for SAVR, driven by the cost of the TAVR valve, which remains about $32,000 in the United States. In yellow now we're showing the costs for the remainder of the hospitalization related to the ICU, non-ICU length of stay, and all of the ancillary care. And you can see this was about $16,000 lower in the patients who received TAVR. And then the physician costs were lower with TAVR as well, largely because of the difference in anesthesia costs. When we sum all of these together, the costs for the initial hospitalization were virtually identical between the two treatments, with just about a $600 per patient excess with TAVR compared with surgical AVR. These slides now summarize the follow-up costs over the ensuing 24-month follow-up period. And what you can see here is actually very similar to what we saw in the intermediate risk group, with perhaps a slightly less, slight lessening of the difference. But you can see between discharge and 30 days, there were cost savings of nearly $3,900 per patient with TAVR. These persisted and actually increased a bit more between 30 days and 6 months, another $1,500, which was statistically significant. And then there were modest but non-statistically significant catch-ups between 6 and 12 months and 12 to 24 months. When we added all of this together, looking at the 2-year follow-up costs, they were about $2,600 lower per patient with TAVR compared with surgical AVR. So when we add all of the costs together, what we can see here in red is the initial hospital costs, in yellow are the follow-up costs, and the total 2-year costs or about $2,000 per patient less with TAVR than with surgical AVR, even though the TAVR valve was much more expensive. This was not statistically significant, but as you will see, when we combine this with the outcomes data, it is actually a very important cost savings. What about the patient side of the equation? That's the financial side. The patient side is looking at the health benefits, and we have two measures here. We have the utilities, which are a measure of quality of life, and then we have the number of years of life that were experienced during the trial. In terms of the quality of life, as has been presented previously, there was a substantial benefit of TAVR compared with surgical AVR that was present at the 1 month follow-up, and then gradually became equal at 6 and 12 months. So this gap between these two is the quality of life benefit of TAVR related to the much easier and more rapid recovery. And then there was actually a small survival difference in the trial as well, which translated into a small difference in the number of years of life gained. And so when we combine these together and look at quality adjusted life years, 1.71 quality adjusted life years with TAVR, 1.66 with surgical AVR, you can see the difference is about 0.05 quality adjusted life years over the 2-year period, which was borderline in terms of statistical significance. So now I'm going to show you the cost effectiveness data plotted on the cost effectiveness plane. We show on the horizontal axis the difference in quality adjusted life years over the patient's lifetime and the difference in cost, again, over the patient's lifetime. But remember, these are really the 2-year data because we're assuming in the base case there was no difference in survival or costs beyond 2 years. So this cloud of points represents the joint uncertainty in both the quality adjusted life year difference and the survival difference. Most of what you can see here is there is some variability here, but the vast majority of these points are in the lower right-hand quadrant, indicating a fairly consistent story of lower cost and higher quality adjusted life years within the trial period for TAVR compared with surgical AVR, although there are a modest number of points that are in the other quadrants. The base case was a cost savings of about $2,200 per patient with TAVR and a difference in quality adjusted life years of 0.049 years. That's what's shown in the red. This green line now represents a cost effectiveness threshold of $50,000 per quality adjusted year of life gained, which is considered highly cost effective in the United States. And when we look at that line, what we could see here is the probability based on the observed data in the trial that TAVR is economically dominant, saving money and saving quality adjusted life years was about 84%. And then the probability that these points are below this threshold line of $50,000 per quality adjusted year of life gained is about 95%. So we are relatively highly confident that TAVR is a highly cost-effective therapy, at least over the first 2 years of follow-up compared with surgical AVR. And we did a number of pre-specified subgroup analyses. As shown here, there are two that are worth highlighting in terms of the amount of cost savings. The group of patients with New York Heart Association class 3 or 4 heart failure, and those who had a baseline KCCQ score of less than 70. These are fairly similar groups, the patients who were most symptomatic coming into the trial. And for these two groups, TAVR was economically dominant with a very, very high probability of being cost effective. But you can see, most interestingly, the cost savings were substantially greater in these more symptomatic patients than in the overall trial. As I mentioned, we did a number of sensitivity analyses, and one of them was looking at the impact of minimalist TAVR. The Partner 3 trial was enrolled in 2016, 2017, and we all know that we've continued to make progress in minimizing the intensity of care given to the TAVR patients. So here is our base case analysis. This is a sensitivity analysis in which we assumed that patients who had an uncomplicated procedure would not go to the ICU, and you can see now that the cost savings during the initial hospitalization is actually in favor of TAVR, and the 2-year cost difference is about $2,800. 97% chance it is cost effective within under that assumption. And if we make a slightly more aggressive assumption that all the patients whose TAVR procedure was uncomplicated in this low risk group were discharged in 1 day, the initial hospital cost savings were substantial. The 2-year cost savings were even more significant, and there was a 99% probability that TAVR was cost effective at that $50,000 per quality adjusted year of life gain threshold. Finally, the last sensitivity analysis I want to talk about is one where we made different assumptions about the long-term outcomes, because obviously we only have 2-year data now. The future is uncertain here. Our base case assumption was that there was no difference, a hazard ratio of 1. But what you can see here is the impact of assuming slightly higher hazard ratios for late mortality, assuming that TAVR might have a small increase in long-term mortality compared with surgical AVR. And now what we're looking at here is the incremental cost effectiveness ratio for surgical AVR. And what we can see is as that hazard ratio for late mortality increases, SAVR becomes progressively more cost-effective compared with transcatheter aortic valve replacement. And for example, if we're willing to spend $50,000 per quality adjusted year-to-life gain, what we can see here is that SAVR would actually be the preferred therapy, as if the hazard ratio for long-term mortality is 1.05 or greater. So this really highlights the importance of the long-term follow-up in really resolving some of the residual uncertainty in this space. So just to go to a couple of quick conclusions, based on the data from the PARTNER 3 trial through at least 2-year follow-up for patients with severe aortic stenosis and low surgical risk, transfemoral TAVR with the SAPIEN 3 valve was cost-saving compared with surgical AVR at 2-year follow-up, and is projected to be highly cost-effective over a lifetime horizon as long as there are no differences in late mortality between the two strategies. Given the importance of the long-term outcomes in these projections, as I've shown, 10-year follow-up is ongoing, and that will be critical to ultimately determine the optimal treatment strategy for such patients from both a clinical and an economic perspective. Thank you very much.
David, that was excellent. We're going to move on to the next presentation. Eberhard, could you please introduce Dr. Koudali?
I'm very happy, and I'm excited to introduce a very good friend and colleague, Sushil Koudali from Columbia University Medical Center in New York. We've been friends for many, many years, and he will give a presentation on transfemoral tricuspid valve replacement in patients with tricuspid regurgitation, the 30-day results of the Trisense study. Sushil, great to have you with us, and the floor is yours.
Thank you, Eberhard, for the kind introduction, and thank you, Marty, and the organizers for the opportunity to present here. And this is a presentation from TCT of last year, and it's looking at the tricuspid valve replacement in patients with TR and the 6-month outcomes from the Trisense study. These are my disclosures. So we've understood over the last sort of 10 years and increasingly noticed that the transcatheter options for tricuspid regurgitation is an unmet need. And there's been multiple studies, this is just one, showing that with increasing degrees of TR, outcomes worsen, including mortality. TR is increasingly prevalent in the US, at least 2.4 million patients suffer from it. It is undertreated, and approximately 10,000 surgeries done per year. And right now, medical therapy options are limited mainly to diuretics and blood pressure control. So this trial used the Edwards Evoke system, which and here you see a brief animation. The device is delivered over safari wire placed in the RV apex. The valve itself is a dual frame design nitinol valve, which you see here is then the anchors are slowly unsheathed and expanded. The anchors are then withdrawn to the annulus to engage the cords and the leaflets. And then eventually, when it's at the level of the annulus, which is all positioned under echo guidance, the valve is fully unsheathed and it anchors into the annulus. And the valve uses the retention force of oversizing at the annulus as well as anchoring on the leaflets and cords to remain in place. There are currently 3 sizes, 44, 48, and 52. They're all delivered through a 28 French transfemoral delivery system. And they all share the same internal size bovine pericardial valve. The Trisense study was a prospective single-arm multi-center study to evaluate the safety and performance of the Edwards Evoke tricuspid valve system. The trial oversight included a central screening committee, an echo core laboratory, and a clinical events committee, as well as a data safety monitoring board. All patients had moderate or greater TR, and they had signs or symptoms of heart failure despite optimal medical therapy. And they all underwent replacement with the Evoke transcatheter tricuspid valve replacement system. The endpoints were device and procedural success, as well as a composite of major adverse events at 30 days. This is the 6-month presentation, but follow-up is ongoing annually out to 5 years. These are the sites across the US that participated and enrolled patients in the study. So at the time of this presentation, there were 132 patients enrolled. We have 6 months follow-up here on 56, and you see the reasons for follow-up not being available. A lot of it is just that patients haven't reached the 6-month endpoint. And here is the baseline characteristics of the trial population. It was an elderly population, mean age of 79, and about three-quarters of the patients were female. They were all high surgical risk, as there is no risk score for tricuspid valve replacement, but for STS for mitral valve repair was 7.4 and Euroscore 2 was 5.3%. All patients were very symptomatic with 70% class 3 or 4. And it was severe TR was present in 88% of patients or greater. Here you see the comorbidities. AFib, an important one, is present in 90%. And there were also presence of other important comorbidities, chronic kidney disease in more than half of the patients, pulmonary hypertension in 79% of patients, and prior left-sided heart surgery, either CABG in 20% or prior valve intervention in 38% of patients. And you see also 20% of patients had ascites. The majority of patients had functional TR, 70%, but you see a mix of others, degenerative and mixed. And about 35% of patients had a pacemaker or ICD in place prior to enrollment. All procedures were done percutaneously through femoral venous access. The majority, 94.7%, were through the right femoral vein, the remainder through the left femoral vein. Device success, defined as device deployed and delivery system retrieved, was achieved in 96.2% of patients, all but 5. And the average implant time was approximately 72.8 minutes. The median length of stay was 3 days. The majority of patients were discharged home, 88.4%. The remainder were either home with services or skilled nursing facility in the remainder of patients. So again, a vast majority went home from the procedure. Here's the important slide looking at the major adverse events. There were 3 cardiovascular mortalities with a rate of 2.4%. And overall, the MAE rate was 18.5%. And more than 80% of patients did not have an adverse event at 30 days. The majority of adverse events were bleeding events in 17.7%. It's important to note that the majority of these were not vascular bleeding events, and they were related often to other problems in this elderly comorbid population, including GI bleeding, urinary tract bleeding, and other events. Access site complications occurred in 2 patients, and in 2 patients underwent surgery for valve malpositioning or embolization. And at 30 days, the all-cause mortality was 3.2%. The other potential complication with replacement that was looked at closely was the rate of new permanent pacemaker. If you look at the 76 patients that didn't have a pacemaker at baseline, there were 8 patients that underwent a placement of a new permanent pacemaker for a rate of 10.5%. Importantly, this device works in terms of eliminating TR. And so you look at discharge, 97% of patients had either mild or non-trace TR, and 3% had moderate. At 6 months, 100% of patients had mild or non-trace, with about half having none or trace. There was a 2-grade, all patients had at least a 1-grade reduction. There was a 2-grade reduction in 98% of patients at 6 months. And there were approximately 10% of patients that had a 4-grade reduction. So very dramatic reduction in TR severity. This is the Kaplan-Meier curve for looking at major adverse events. And what's important to note is after 1 month, the curve is relatively flat from 18% to 20% at 6 months. And for survival, again, very flat at from 97% at 1 month to 96%. And the freedom from heart failure rehospitalizations at 6 months was 94%. It's important to note that this is a population that in the year prior had a 40% rate of hospitalization. So this is a dramatic decrease in the rate of heart failure hospitalization. And there were significant improvements in other measures of functional status and quality of life. NYHA class, majority of patients, as I said before, more than 75% were class 3 or 4. At 6 months, 89% were class 1 or 2. And this is a paired analysis. In terms of 6-minute walk distances, they improved significantly by 56 meters, which is about 25%. Again, KCCQ improved dramatically by approximately 27 points, which is from a very low baseline of 48.6 to 75.6 at 6 months. So to wrap up, transfemoral tricuspid valve replacement with the EVOQUE system demonstrated favorable 30-day outcomes, which were sustained at 6 months. There was significant TR reduction by core lab assessment, with 100% of patients having mild or less TR at 6 months. The survival rate at 6 months was 96% by Kaplan-Meier analysis, and there were freedom from heart failure rehospitalization was 94%. In addition, there were significant improvements in NYHA class, KCCQ score, and 6-minute walk distances. Patient follow-up is ongoing in this EFS cohort. And based on the results of this cohort, the randomized pivotal trial, Trisense 2, was initiated and is underway, evaluating transcatheter tricuspid valve replacement in comparison to optimal medical therapy in patients with symptomatic functional tricuspid regurgitation. Thank you very much.
Thank you very much, Sushil, for this excellent presentation. And we're all excited to see these great results, for the tricuspid valve replacement. Marty, are we shifting to the discussion now?
Yeah, I think we'll have a short discussion. And I was going to start by referring back to Nicholas von Meegen's presentation on the 5-year results from Certavi. And I was going to ask my good friend Eberhard a question from that study. So now we have 5-year results from Certavi. It's a large study, intermediate risk, and there is no difference in either clinical outcomes and even the echo findings at 5 years. And these are core lab echo findings, actually showed a benefit of the self-expanding valve compared to surgery. And you're aware also of other data that's out 5 to 8 years with self-expanding valves. We've presented 5-year data with SAPIEN 3 compared to surgery in intermediate risk. And we aren't seeing very much of a difference. Can we say at this point, or do we still have to wait to say that these transcatheter bioprosthetic valves, at least in the clinical trials, are performing as well as surgery, and durability really should not be a major question as it was years ago?
Yeah, I think this is a very important question, Marty, for actually both valves. And if we put things into perspective now on the mitral and tricuspid field, we can be really looking very proudly of what this field has achieved over the years with randomized trials. The question of durability, as you recall very well, was from the very beginning a kind of a little battlefield between intervention cardiologists and surgeons, because they said, you don't have long-term data and we have to wait. The question then was, well, time will tell. Obviously, we cannot do a fast forward when we started this, but now looking at 5-year results for both valves, there's absolutely no sign that indicates something that we should be careful looking forward and saying, well, maybe we have to wait another 2 or 3 or 4 or 5 years. I think there's no sign that would indicate any risk of durability issues. And hopefully, for the next 5 years, we won't see anything else. Eventually, things will be different maybe, but for the time being, I think it is very, very promising. I feel very confident for both valves, given the results of both trials. There's no difference between surgery and TAVR. Good work that has been done, and I think it's a very, very bright outlook for the future.
Thank you, Eberhard. David, your analysis is always so articulate, so beautifully presented. But I was struck when I listened to the study this time, how important some of the sensitivity analyses are. And really, it's a snapshot in time. It depends on what the cost of the valve is. It depends on how the procedure is done. We did minimalist TAVR in those days less than half the time. At Emory, they do it in 98% of the patients. And the follow-up was only 2 years. And you pointed out the issue of how very subtle changes in clinical outcomes that occur years later can really affect these analyses. So when you interpret the data, what do you tell healthcare systems? Because the health economists are talking about this. how do you frame the argument, realizing that these analyses are only a snapshot in time?
Well, I think it's a really important point is that we do get snapshots, and as practice evolves, then our the answers will change to some degree as well. I think for the most part, the sensitivity analyses are very reassuring. They only tip things further in favor of TAVR. For example, the minimalist analysis says that we can, or at least over the 2-year follow-up, the cost savings that we saw that were about $2,000 per patient could go up as high as about $3,500, $3,600 per patient to the healthcare system if we fully implement some of the minimalist techniques that the Emory group and the Vancouver group have really shown us can be widely applied. And we know now in the United States today, the median length of stay after TAVR across all risk groups, not just the low risk patients, is a day. I mean, so we are, every year we get closer and closer to achieving that ideal. I think, the one part where, again, Eberhard highlighted this, you did already, that we don't, we can't do at least a easy analysis to answer is this long-term outcome with respect to mortality. And I think, in the low risk patients, is it likely we're going to see a mortality benefit in favor of surgery? I don't think it's very likely based on everything that we know so far, based on the excellent results we've seen with both valves, both from a hemodynamic and a paravalvular leak perspective. The one thing that really still is unknown that we can't easily accommodate in our sensitivity analyses is the management of late valve failure. And I do think that is an area where if more data are necessary and will be instructive in terms of determining the value of these therapies for these low risk patients who have, have good, really good surgical options as well, is if it turns out that, that a lot of these patients require a valve explant or something like that in order to manage late valve failure that is, likely to happen at 10 or 15 years, that could be a very different story. And so I think we still have, there is still an open question about the very long-term outcomes of the low-risk patients. Of course, we'll all come back and, when we have the 5-year results and the 10-year results to see how they affect things and how they affect the economics. For now, I think that, as Eberhard said, I think the future is still very bright.
Marty, can I ask a question to Sushil? I know time is short, but here we have an operator that has extensive experience with the mitral and the tricuspid field. Sushil, if you look at these two fields, and obviously we are tempted to compare mitral and tricuspid, would you enlighten us with your wisdom or your feeling as to the situation of valve replacement in the tricuspid versus mitral? Is there a difference? Should there be a difference? And looking at the surgical competitors in both fields, we know that the surgical approaches in tricuspid is not very promising. So we are much easier, have a much better outlook for the tricuspid. Is there any different value in replacement tricuspid versus mitral?
Yeah, no, I'm not sure I have the wisdom, but I think it's an early. It is interesting. There are some key differences. I mean, anatomically, there's a lot of differences. In terms of anatomic restrictions, you don't have the concern about LVOT, but you have the issues with a very large asymmetric annulus. We see diameters of 7 centimeters. And the other real issue that we have on the right side is the lack of data, meaning we don't have an understanding of RV function. I mean, we struggle. We say we excluded patients with severe RV dysfunction, but we don't even know how to define severe RV dysfunction. There's this whole concept of RV-PA coupling in terms of what the RV can compensate. And we need to understand which patients are going to benefit and tolerate this procedure versus which are not. Where on the mitral side, we have decades of data and we understand the surgical outcomes. We understand how those patients do. And the other big difference is we have therapeutic options on the mitral that are just not understood on the tricuspid, whether it's medical therapy, and the medical therapy for functional MR at least is continuing to evolve with new data, including SGL2 and other classes of drugs, that on the tricuspid, there's no goal-directed medical therapy. It's just optimal medical therapy, which is diuretics. And so, that issue you raise is what is the competitor? There's not a class 1 indication in the ACC guidelines for operating on isolated TR in contrast to mitral disease. And, and that's been seen in the endpoints of these tricuspid valve studies. The comparator is not surgery. The comparator is optimal medical therapy, and the endpoint is a heart failure endpoint. It's a composite, including mortality, including tricuspid valve surgery, but it also includes heart failure hospitalizations, quality of life, 6-minute walk, and other factors. So there are key differences based on, what we know about the disease process, about anatomic restrictions, as well as what are the goals. I mean, do we need to eliminate TR or do we need to reduce it to allow medical therapy? So there's just a lot of learning, and we need to, I don't have the wisdom to sort of say where this, how it's going to move forward and which device, when, but this early stage is very exciting. This is where we're going to learn.
Yeah, I think it's interesting. And I think Eberhard's question is a great one. That among the inflow valves, a lot of the excitement is shifted from the left side to the right side of the heart. And I think it's probably fair to predict that there'll be an FDA-approved transcatheter tricuspid valve before there will be an FDA-approved mitral valve. Despite the fact that there was an almost decade lead in terms of initiating these therapies. So the studies are moving quickly, and certainly Trisense is a landmark trial, and congratulate all the investigators and leadership of that study. We're going to move on, if that's okay, and I'm going to turn it over to Juan Granada, who's been, really the soul and the spirit behind the Shark Tank presentations at TCT, which really have become a highlight of the innovation sessions. And he's going to help to summarize the best device and innovation concepts from TCT 2021 and THT 2022, which is a meeting that was just concluded last week in New York City.
Marty, thank you for the kind introduction, and thank you to our friends from TCT Asia Pacific for keeping us involved in this great meeting. As Marty said, the Shark Tank Innovation Competition is becoming an extremely important component of all our meetings. This is my disclosure statement. I'm not going to present any companies that actually have any affiliation with the Cardiovascular Research Foundation. As a matter of fact, we have very strict protocols, and no companies essentially are presented if there is any specific affiliation with the foundation. Over the last 7 years, we have screened over 300 companies in these competition, and we have created an amazing platform to identify and actually promote leading edge cardiovascular technologies. We have created, I mentioned, very, very good partnerships with organizations such as the Fogarty Innovation Group, Biodesign, Stanford TriVentures, and BioStar Capital. And an important affiliation we have is with the John Deehan Foundation that is actually giving us a monetary award that essentially increased the visibility and the importance of this award. As I said before, we have a screen over the last 7 years, 300 companies. In the last 2 years, around 100 companies, including THT this year. So essentially what I did was to select the companies that had the highest grades, and they are very innovative and actually out-of-the-box companies. One interesting company that won in 2020 is this company, Ultraside. And it's extremely important and exciting company because essentially takes away the need of significant training to do ultrasound in patients. Based on artificial intelligence, pretty much once you put the probe in the chest of the patient, pretty much the screen walks you through the process to actually get high quality images. This has actually simplified the acquisition process and essentially allows the standardization of procedures, real-time guidance of acquisition, and essentially give access to ultrasound in areas in which ultrasound is needed, especially in times of COVID, in which the number of technicians has decreased. This is a technology that can really have an important impact in areas in which complex ultrasound imaging is required. The next company that was presented at THT is TCT, actually is quite interesting. And the name of this company is Acropas, and is a company that is aiming to treat fluid overload in a non-invasive way. As you can see here, they have a dedicated vest that creates a microclimate around the body and pretty much increase perspiration at a rate that is actually close to 200 millimeters per hour. Typically, they use a 3 to 8 hour session, and you can actually see data from the first in-human study in 17 patients, in which they were able to essentially have rates of perspiration, or sweat rates as they call it, of 200 millimeters per hour. In an average of 4 hours, they were able to essentially take approximately a liter out, which actually becomes a very interesting therapeutic approach for patients with fluid overload and congestive heart failure. This is the winner of THT this year, and it is also aiming at fluid overload, but in a different way. This is the Doria system, which is a temporary, induces a temporary partial obstruction of the inferior vena cava below the renal veins. And by decreasing the renal venous pressure, essentially force the pulling of blood from the renal veins and essentially enhance diuresis. This is the first in human study result, again in a small number of patients, where they demonstrated an increase in urine output, decrease in renal afterload, significant increase of edema after 48 hours of use, and improvement in symptoms as well. Another interventional heart failure therapy that essentially gained a lot of attention during THT is this company Axon. And essentially what they're doing is proposing the unilateral ablation of the right greater splanchnic nerve, and is designed to interrupt the sympathetic nervous activity to the splanchnic bed, then reducing actually congestion, so essentially decreasing preload. This is very similar to renal denervation. It's an hour procedure, skin to skin, and patients actually can be treated as outpatients. They have very solid actually surgical data, and the first endovascular experience was completed with 12 patients. And you can see here significant reduction in BNPs at 3 months, improvement in functional class reflected, as you can actually see, by the KCCQ over score and actually walking distance as well. This is another actually out of the box concept that is actually called this one, that is using a pacemaker, a diaphragmatic pacemaker that is inserted laparoscopically. And essentially they're essentially aiming to change the intrathoracic pressure to induce micro reduction of the pericardial pressure, increasing essentially preload. You see the first in human study here in which the pacemaker was switched on and off. And you can see here that cardiac output was increased by 17% on an average of approximately 10 milliliters per beat. This is the winner of actually the TCT innovation competition last year. And it's actually interesting that was not a cardiovascular technology, it was a pulmonary technology. This is a company, the name is Lung Pacer, and essentially is aiming to increase or actually reduce ventilation times, reduce winning rates, and essentially trying to get patients out of the ICU by inducing essentially pacing of the diaphragm. It's a very simple catheter that is inserted through the left or right jugular vein, and they have essentially a system that induces pacing of the diaphragm, as you can actually see here. And by inducing pacing of the diaphragm, they think the patients actually are going to be able to really go out of ventilation. This was extremely important during the times of COVID, and multiple trials were done, and they were able to demonstrate improvement in diaphragm movement, improvement in lung function, and actually all the improvement of parameters of ventilatory function that allowed patients to go out of the ICU. This was actually, the winner was actually extremely well accepted by all the judges. Just finally, one highlight technology on digital healthcare. And the name of this company is Viewmind, and they are trying to develop digital biomarkers for neurological disorders. By the use of a VR headset and dedicated software based on AI that essentially tracks the eye movements, they're actually able to develop a technology that predicts cognitive dysfunction ahead of time. This is actually the first study that they did, a small study in patients with mild cognitive impairment with 4 years follow-up, that essentially they predicted 34 cases were going to undergo Alzheimer's, and they predicted Alzheimer's in 94% of the times. And 29 patients, they predicted they were going to be okay, and essentially the negative predictor value was 100%. So they were actually moving forward with pivotal studies in the US, and this is an exciting non-invasive tool that can be used for multiple neurocognitive disorders. So this is the summary of the top 7 companies that had actually the highest grades. Of course, there are many companies on the structural space, tricuspid, mitral, etc. But actually thought that would be actually refreshing to actually show, very out of the box technologies that are potentially actually can have a big impact in the cardiovascular space in general.
Juan, thank you very much. That was really fabulous. It really just shows the diversity and the creativity of new technologies, transcatheter, digital, and otherwise, that certainly affect structural heart disease, but also that are really impacting medicine. So it's really nice to see some of these new presentations. It just shows us that innovation is alive and well even during a pandemic these days. Juan introduced this meeting, THT, which we just concluded in New York. It's the first time we've done a meeting in heart failure therapies, and we think that's going to be an important area that we can share with our colleagues in Asia in the future. So we want to conclude this session with a final presentation, which to me was truly among the highlight live cases that were done at TCT in 2021. And I have to credit my great friend and colleague, Adam Greenbaum, for his pioneering spirit and his courage to do a live case like this. This was only the 8th patient ever done using a new technique that really features a lot of the electrocautery experiences that the Emory and NIH groups have brought to structural heart disease, and now directed them to the treatment of obstructive hypertrophic cardiomyopathy. So Eberhard and Juan will help us moderate this, but this will be an edited version of the live case, and Adam can provide appropriate commentary and answer some questions at the end.
We are Emory. This is a big team. If you want to put up our slides, we do have a lot to show you. So in the interest of time, we're going to go right to the case presentation. Maybe next slide. And Eric.
Today we have an 87-year-old woman who presents with severe mitral stenosis secondary to severe mitral annular calcification. She has NYHA3 heart failure symptoms and a mean gradient of 13 millimeters. She is high risk for open operation per our STS score calculation. During our CT analysis for a possible transcatheter mitral valve replacement, we found that she had a mitral annular cell was amenable to transcatheter approach based on its size and the degree of annular calcification. However, if you focus on the left lower panel, you'll see that placement of a valve would lead to impingement of the ventricular aspect with the LV septum. When we did our area analysis, we found that the neo-LVOT was indeed 0, and even if we were to perform a lampoon, the skirt neo-LVOT would only be 150 millimeters. On top of that, she has an LVOT gradient at rest that's 80 millimeters and increases to 120 during Valsalva. So she clearly needs a treatment that increases her LVOT volume. So we reviewed her coronary anatomy and found that she did not have a septal perforator that was amenable to alcohol septal ablation.
So this is a common scenario, as you know, where we need to thin out the septum. We need to make room. Of course, the traditional gold standard and a great approach to this is surgical myectomy. As you guys know, our group, the team here in collaboration with Rob Letterman and the crew at the NIH, we spent the last 5 years trying to mimic some of these excellent surgical procedures with transcatheter electrosurgical principles, such as Lampoon. Of course, the next logical procedure to tackle would then be surgical myectomy. But all kidding aside, based on a clinical need with issues surrounding alcohol septal ablation, we asked ourselves if we could mimic a surgical myectomy using transcatheter electrosurgical principles.
So we've invented a new transcatheter ventricular myotomy to treat HOCM or TMVR-related LVOT obstruction. And it just requires two transfemoral guiding catheters, one positioned at the basal anteroseptum, and the second in the left ventricle, which houses a snare. A stiff angioplasty guide wire is pushed into the septum and backed by a microcatheter, and is then shaped with a CTO tip and navigated along the desired trajectory that we want to border our myotomy. It is then pushed to exit back into the left ventricular cavity where it is snared. We then form the classic flying V, and with transcatheter electrosurgery, electrify the wire and pull the catheters, lacerating the myocardium and the myotomy. Now, this is a simple laceration, but the circumferential fibers in that septum pull the muscle apart, splaying the septum away, creating more room in the LVOT and reducing that gradient. So I'll hand over back to Adam to show you what's next.
So if you're asking yourself, have we done this yet? The answer is yes. In fact, we've done it 7 times to date, and this is the first patient that was done back in January, and you can see the hypertrophy and post Sesame and then actually TMVR. You can see the room that we've made to allow flow out the LVOT. And
see, we're right below the sapien valve with the hockey stick. We have a marker pigtail, and there's really complete obliteration of the LV in both the A and the B plane. So from this point, you can go forward. We are able to put the hockey stick right in the appropriate orientation. You see we're injecting against myocardium, and then using the cut end of a Confianza Pro 12 through a microcatheter. In this case, we're using Caravel. We can put some rotational spin on the wire and get it right to the myocardium in 2 views, tracking a little bit deeper here into the myocardium. And then we'll do 1 more V-gram. You can see the Caravel coming behind it. And this is a V-gram now with the wire in. You know, hopefully you guys can see, you can see the mitral disease. You can see the giant hump that we're cutting through in the A plane. You can see the obliteration in both views. So we're partly into the myocardium, and this is a patient who had a lot of gradient at baseline, a lot of provocable gradient. But what we're seeing in these patients referred to us for MAC, a lot of them have this variant hypertrophic cardiomyopathy is putting a lot of tension on the mitral, degenerating it with calcium. So we're trying to address the myocardium as well. This patient needs room, obviously, for the TMVR, and also has provocable gradients and resting gradients. So there's lots of reasons to do this.
Let's just go to X-ray for a second. Okay. You can see that Adam and Vasilis have snared the guide wire that traversed the septum, re-entered the LV cavity, and now they've ensnared it inside the LV cavity. Now they're pausing, just like in a basilica procedure, to create a flying V type lacerating surface.
So we have made the flying trapeze. Jaffer.
We need to have chemo during the laceration.
We have glucose hooked up, because everybody understands that principle. We're not going to go over that again, but it's only hooked up to one catheter, the catheter that's in the LV, because the other catheter is far away from the lacerating surface. So we will inject one catheter. We also, unlike Basilica Lampoon, are not going to pull both guiding catheters, because one guiding catheter is up against muscle at the base. I'm going to pull that piggyback. So my hand will be on piggyback on one side and the catheter on the other, and we will lacerate.
Can we go to 50 on the...
we're going to go to 70 on the
Chris,
power.
we need to see biplane X-ray.
But let's make sure that we're ready to go. But so there's a Caravel right up to the denuded segment, piggyback on the other side. Again, the denuded part is in between them. That is the muscle, right? The catheter that's in the LV cannot dig into muscle, so it's right up against it. You also notice that we did pull it back, so you can see we're not caught under any cords because we're sort of right where we exited.
Would it be possible to get echo on the screen at the same time as you're doing it?
Absolutely. Sure. We'll go
You want to do a
everything.
quad or?
That looks good.
Yeah.
Becky is texting me asking if the gastric would show the laceration, so I'm just going to throw that out there.
Yeah, we typically go to the gastric right after they lacerate.
Okay.
Everything we've done for the most part is on 70 watts, so we are on that.
And what maneuvers are you going to do to protect the aortic valve?
So we will often do a two-step burn. We may come 3/4 of the way, intentionally stop, and then we may get ready. The person who is on the bovie, the second we get through that last bit of muscle, will get off the diathermy pencil so that we don't injure the aortic valve.
You also likely see that the denuded segment invaginates into the catheters as soon as it releases from the muscle, but we'll see.
So here's some things you're going to want to watch. The position on X-ray. You're going to watch the hemodynamics and look at rhythm perturbations, if there are any. So far, we've seen very few that are not just mechanical. And then you can see some transesophageal echo as well. So Cecile, you're going to have to look at 4 or 5 different places at once.
What kind of energy are you delivering from the cautery?
70 watts pure cut.
You go live on biplane just to see.
Sure. And it's going to be constrained to just that lacerating surface between all the other insulating surfaces.
You want to burn?
Yeah, let's go.
Okay, so
I'll burn.
I'm going to grab. I'm loosening the TUI on the piggyback side because again I'm pulling catheter only.
And that one's
On this
all live
side.
right now.
Let me get it a little closer here.
It's all the way up.
Oh, it is. Okay.
Yeah.
All right. So I'm going to grab here, and I'm going to grab here. So in my left hand is the piggyback. That's the higher one. In my right hand is the catheter. We're going to try and just toggle this back and forth and go. And if we don't like what's happening, we will stop. Okay. So here we go. You want me to call it?
Yeah. Go ahead.
Okay. So start the infusion. Sitting.
Dextrose.
Bovie on.
See the bubbles, which
We'll stop right there. We just have one little bit to go. Are we ready? We need more dextrose, and we're going to be on this for less than a second here.
Make sure this catheter
Yeah.
is down.
You can see here that
You ready?
you've already got a nice
Infuse.
cut.
Cine.
We don't see the fluid.
Bovie.
You see.
That's it. We should be through.
You are through. Here's a nice.
Let's let Patrick talk about the TE.
Yeah, Patrick, take us.
Oh,
take
wow.
us home.
That's a nice image there. Yeah, can you show that for all of us?
Yeah. So here we have our transgastric short axis, and you see our nice, laceration right here. And we'll put on color, make sure that there's no VSD. But as you can see, there's no communication here between the left ventricle and right ventricle, and you have filling in systole.
You want to pull?
It looks great.
What do you think?
What about if you maybe do PVC? Yeah.
Sure. She's still, just so you know, she's still going to have a provocable gradient post PVC because, again, there's a lot of thickness to that myocardium. We'll try and induce one here for you. There you
Well,
go.
we suspect that this is going to evolve over
So-
time.
But if you look, that's less. Your baseline gradient is less.
Yeah.
We want to understand where this fits in therapy, if this even is a promising therapy. So far, it seems very promising and very thought-provoking because there are a lot of other variant procedures that we hope to explore in the coming years. And we're glad you allowed us to share this with your audience here, and we're really interested to hear your thoughts.
Adam, amazing procedure. I have to say it's congratulations. Also, I think Juan and Marty, it's amazing what you've done, and the team created a very, very interesting procedure for alleviating the obstructive cardiomyopathy in a very elegant way. And the way you're doing this, it looks very easy, very slick, and not very complicated. Obviously, there are questions that are raising. And Juan, maybe you can take it from there.
Marty said it. The speed of development on the tricuspid side relates to the complexity of the anatomy on the left side. Putting sizing issues aside, is all about LVOT. And even if you improve and optimize frame design, I think LVOT obstruction will continue to be the Achilles heel of mitral replacement technology. So this can really, open up a lot of opportunities for TMVR devices in the future. I would even say for potentially surgical patients as well. So this is really unbelievable, and I really think that this is going to open up the field, that is going to help the evolution of this complex field as well.
Adam, could you give us some insight? If you compare the procedures, complexity, Basilica, Lampoon, and the Sesame, what's your perspective on that? Is it less complex, less complicated? Can this be done by an average operator? Obviously, with a team and experience.
Sure.
But what's your perspective on that?
So all great thoughts. I agree, Juan. The number one exclusion for TMVR trials right now is LVOT obstruction, right? And Lampoon, although it addresses the leaflet, will not help in the situation of these fully covered valves that are being developed. So the need to reduce the septum is huge. And maybe part of all future TMVR projects. And we're really high on this procedure for a couple of reasons. One is, I think we have the potential for less heart block because we know exactly where we want to enter. We enter between the nadir of the right sinus and the left-right commissure, so we avoid the conduction system. Whereas alcohol, you just don't have that necessarily that ability. We're not really killing any myocardium, right? We're just making a clean slice. And the other advantage is we know depth. The surgeons tend to under-resect because they can only see what they can see. But since we can see, as you saw in that ice picture, right, the full thickness, we know the depth. So we should be able to avoid VSDs or avoid under-resection. So all that being said, we're pretty high on the procedure. Now, as for the complexity, it's certainly not ready for prime time yet. We've now done 11. We have 2 more scheduled in the next couple of weeks. The main issue here is understanding where to start, how deep to go, where to re-enter. And in order to do that, we need to see very well. As you can see, as you saw during the case, there's some limitations in our ability to see. We're using a transseptal ice catheter to try and get as close a picture as we can to depth. But I think as imaging technology gets better with us, I think this procedure has the potential to replace actually all alcohol septal ablation and actually all surgical myectomy. If you had HOCM and you were 35 years old and said, hey, why not do this first and see if it works? So really it could be revolutionary to the field. Obviously, like all the procedures we've invented, it would be nice to have industry partners, right? These weren't meant to be, these were meant to be taken to the next level. Some dedicated tools would certainly help. But I believe that transcatheter slicing or removal of myocardium in the LVOT has a bright future.
Amazing.
Just some final comments. This was an extraordinary case, and I really wanted the Asian audience to see this because the acceptance of LV myotomy, myectomy in Asia is not as great surgically. There are already catheter-based, even percutaneous procedures that are being done with RF ablation in obstructive HCM in China. There's a large center in Xi'an that has done over 100 cases. So this trend to catheter-based treatment of HCM, which, believe it or not, began about 30 years ago with Jeff Isner using laser catheters that I was peripherally involved in when I was at the NIH, has now taken a totally new form. This procedure, the troponin rise here is 0. There's no troponin rise. There's no effect on LV function. There's no effect on the conduction system. So if you can avoid ASDs, if the imaging gets better, if you get purpose-driven equipment and centers that develop expertise in this technique, this could be the treatment for obstructive hypertrophic cardiomyopathy in the future. So the opportunity to see that at this stage by the extraordinarily talented group at Emory was really a treat. So Adam, thanks a lot. This was really a great experience, and it really builds on your whole electrocautery theme over the past better part of a decade now. So, you know, it's really the culmination being applied to important clinical problems. So,
well, thank you, and thank you for letting us share it with you.
Yes. So thanks to everybody. This was really a fun session. I think the clinical trials, which is kind of the bedrock of structural heart disease, looking at the new technologies through Shark Tank, and now seeing a new procedure. And remember, this was done live at TCT. You saw the edited version. This was done in 55 minutes during a live case transmission at TCT. So this is a lens into the future, my friends. And I want to thank all of our colleagues and associates and friends, especially S.J. Park and his team for allowing us to participate in TCT Asia Pacific this year. Thank you all.
Thank you very much.
Thank you very much.